Okay.
Next up, we have Richard Platt. He's a professor and chair of the Department of Population Medicine at the Harvard Medical School.
Okay. So I'm going to use the next few minutes to suggest a framework that we use when we're talking about electronic health data, and I certainly appreciate recommendations for changing the structure. But it is important that we use terms in more or less the same way, at least for the next 30 hours. So that's the goal here. I'm suggesting that we think of electronic health data as comprising these 5 kinds of data, all of which exist in electronic form for substantial pieces of the population. One slide for each of these, and then a closing thought. So electronic health records, widely disseminated now. A large fraction of the U.S. population has an electronic health record. I guess I'll say, skipping down to some of the problems, most of us have more than one electronic health record, and that's a problem. So the big advantage of these is that they can be available in real time, and they have considerable clinical detail. The disadvantages are that they are highly balkanized. It's relatively difficult to extract information at the level of a population, and it's not so easy to combine the records from one EHR with the records from another EHR. Laboratory data is available in great quantity. It's very timely. It can be extracted without reference to any other system. On the other hand, it's not terribly useful unless it's married to information that comes from another system. So you can't follow up, a public health agency can't immediately follow up a positive laboratory test. For administrative and claims data are available for a large fraction of the population. They have information that's often lacking in other systems, and they have the big advantage that they cover care pretty much everywhere. So although my electronic health record data is in Boston, it won't know anything about the heart attack that I have tonight on the streets of Washington. But CMS will know because it's going to pay the bills. So now that has the big advantage that there is definable person time. It has the big disadvantage that there is limited clinical detail, and sometimes that's critically important, and it is also not terribly timely. There's also prescription dispensing records. By this I mean a substantial fraction of the U.S. population has pharmacy benefits as part of their medical insurance, and therefore when any of us goes to a pharmacy to obtain a prescription, in real time a pharmacy benefits management company knows about that because they know how much my copay should be, and that data can be aggregated. So there's a lot of useful information in that. It's particularly useful when it can be married to some other form of data that we're talking about, and the mechanisms for doing that are not so many. It's certainly true for people who have healthcare insurance, that the insurers can receive that data in relatively rapid fashion. And finally, state or other public health agencies maintain registries that can be critically important. We've talked several times today about the response to H1N1, and the response that we participated in used both insurer data and freestanding state health agency data. The timeliness of those registries is highly variable in our experience, and there's also a lot of variability in what they capture, the mechanisms by which they capture them, and so the need to customize for the various agencies. Okay, that's our quick fly through those. Ways in which I think these connect to our work today is we need to think about, so let me just say, the future will be wonderful. We'll be able to put all this data together, and we will have excellent information about whole populations more or less in real time. The problem is, if we want to put together a system that will be useful for now, we have to think about which pieces of this patchwork we can put together any place, not just in places where the future has already arrived. And we need to think about the fact that almost everything I've talked about is thinking about the delivery of care in conventional settings, and so much of the medical countermeasures response takes place in non-traditional settings. And so we need to be thoughtful about how to put those together. I think the final thing I'll say is that there are lots of important technical challenges about making inherently incompatible systems work with one another, and to do that more quickly than they might do in the course of ordinary events. I think those pale in comparison to the legal, proprietary, and governance issues that exist. And many of those exist for very good reasons, and it will take real thought and effort and goodwill to find ways to make these systems work together for purposes other than the ones that they are primarily designed to serve, and to do that in a way that's still consistent with their original missions. I spend a substantial amount of my time doing this kind of work with people of goodwill in organizations that are trying to support important public health missions, and it's still a lot of work. So I imagine that, so that will have to be a non-trivial part of the kind of conversation that we have over the next 2 days. Okay, thank you. Next.